Okay, we have more people trickling in, but maybe we'll get started as they start to join. So welcome everyone to developing and implementing a mobile addictions medicine service for Indigenous people in the GTA. Some housekeeping items that you've probably heard multiple times at this point already, but you do have the chat box on the side. So throughout the presentation, if you want to put anything that pops up into the chat box, and we'll be saving our questions until the end of the presentation. There will be at least 15 minutes for questions and answers afterwards. If you're having any kind of tech concerns, there is a help button, not on this screen, but if you go to the main platform profile, there's a help button on, I believe, the bottom left that you can get assistance there if you need it. So if anything pops up, you can go there. So as more people are still joining, I'm very excited to welcome our speakers today and to dive into their intros. So we have Harvey Manning, if you want to give a little wave so we know who we're talking about. Harvey Manning is of Ojibwe and Irish descent. He has spent most of his career working in the First Nations community. Some highlights of his career include leading teams to expand and enhance health services for First Nations community members. He was the executive director of Natives Men's Residence, which is the only shelter for Native men in the GTA for which Harvey himself had resided during his early years. He is currently the program director at Anishnawbe Health Toronto and helped implement the first of its kind COVID-19 mobile response in the GTA, which provided services to all community members. Harvey's passion includes learning and teaching First Nations culture and traditions. He continues to promote and collaborate of both Western and traditional approaches to healing at system level. Welcome Chetan Mehta, who did medical school at McMaster and family medicine training here at the DFCM, St. Michael's Hospital, University of Toronto. He is currently the RAAM physician at Anishnawbe Health Toronto, which serves Toronto's inner city Indigenous population. He fell into addiction medicine from his initial experiences in James Bay and subsequently worked at Parkdale Queen West Community Health Centre, the substance use service at Women's College Hospital, Regent Park Community Health Centre, and the Kelowna General Hospital in BC, before coming to Anishnawbe Health Toronto. He is an avid reader of the Mehta listserv. Thanks for adding that, that's fun. Subo Awan is a registered nurse and the interim manager, Babishkan, you'll have to correct me on that one, I apologize, mental health and addictions programs, and Anishnawbe Health Toronto. Subo has more than 12 years of experience in community healthcare with a focus on mental health and addictions, prenatal care, primary care, and needs-based program development. Her passion is to help promote positive health outcomes for vulnerable populations, and her experience includes participating in the development and implementation of community-based programs for individuals living with serious mental health or substance use disorders. She is also in the process of completing the Masters of Health Science program, Health Administration, at the Institute of Health Policy Management and Evaluation at the University of Toronto. Very exciting. So I'll hand it over to you and I'll be here if you need me. Thank you.
Okay, good morning, everyone. I am Harvey Manning. I am from Kettle Point First Nations. And do you guys want anything else to add to your intro or okay?
Yeah, I think that was well done. Thanks, Katie.
Thank you. Thank you. I just want to let people know that we have no conflicts of interest here. And what we want you to get out of this, I think number one, what barriers people in Ontario have in accessing addictions medicine services. Number two, what are the service gaps? Number three, we will specifically focus on the additional barriers Indigenous people have. Next, we will cover reasons why we decided to go mobile with the RAAM. We will get an overview of our history with mobile services. And lastly, what makes us different from other mobiles. Some of the things we cover are access to our services, which are low barrier. First, I want to tell you a little bit about the history of AHT. This, we started in a basement of the Native Canadian Centre. And the Native Canadian Centre was at Spadina and Bloor. It was actually a Bible college before being a Native Canadian Centre. And we, the founder his name was Joe Sylvester, who is an addictions counselor working out of there. At first, the main focus was on diabetes because of the problems within our communities. And from the Native Canadian Center, we moved to Queen and Bathurst, the church down there. It's funny how it's connecting with these churches and what has happened to our people in the past. One of the main services at AHT was providing a street patrol, which looked after the people on the streets and primary health care. Street patrol started in the mid-1980s with a group of community members living on the streets had died suddenly from alcohol disorder and other health issues. Our service was modeled after Kenora Street Patrol services. And that service there in Kenora, which is still running successfully today, run by the Indigenous community members. Our agency made it a priority to respond to this crisis. We provided services in a high percentage of Indigenous men and women living on the streets of Toronto. We recognize that, being out in the streets, there's not just many Aboriginal people, but many people from all races. So we couldn't not serve them. So we served whoever was living outside. And it wasn't just from, many of the people had mental health issues as well. The patrol went late into the evenings and sometimes overnight, often meeting clients where they're at. The success of street patrol was very high, and we were seeing over 100 to 200 people per night. And why would we see such a good thing end? A few things happened on the service became oversaturated with other agencies providing the same service. The city also got involved, and they became involved through a program called Streets to Homes. So Streets to Homes, and there was many duplications of services happening out there. So Anishnawbe Health decided we need to step back and maybe look at this at a different angle.
Okay. So I'm going to cover a little bit about our RAAM and how this relates back to the original mission a little bit later. But I'm going to sort of situate us within the micro, meso, and macro level of the addiction services here. So briefly, our RAAM started in 2018, and as you can sort of see in the last 2 years, we've seen a really explosive growth here in our RAAM. We're located near Allen Gardens in the downtown Toronto core, and we're close to the main areas, Moss Park and Allen Gardens, where there is a sizable amount of alcohol and drug use, and a large Indigenous population in this area. So as you might be able to see from this graph, we've had a 150 to 200% increase year over year so far. And the 2022 numbers really just cover the first 3 months of the fiscal year. Our current team is staffed by one FTE coordinator, 2 case managers, and myself as a 4-day-a-week physician. As you can see from the next slide, which takes a look at the city and where services are located. We're located right in the center where there is a saturation of services and a number of RAAM clinics and safe consumption sites in the area, along with other harm reduction services. So as you can see, most of this is located in the downtown core, And as you'll see from the next portion of this, there's a couple of areas in the city where we've sort of identified our service deserts, so to speak. So areas that are not well serviced and which have considerable need. Okay. So as we were sort of going through the process of, if you want to go to the next slide, of looking at sort of what is the current state of addiction services in Ontario, we just looked at some of the data that was just on RAAM clinics, publicly funded RAAM clinics from Clinics Ontario. And there are a few interesting results. So a lot of the RAAM clinics, so there was about 117 RAAM clinics. The majority of them, there's a sizable number of them that were based in community mental health organizations that were hospital-based. There are a few that are a little trickier to figure out. The Mississauga-Halton region, RAAM services, just from looking at the data, is a little bit unclear to identify exactly what was community-based and hospital-based, but that's sort of the overview of the RAAM clinics that are in terms of the settings that they're located at. Next slide. Yeah. What was also interesting to see is, the service gaps. So, so in terms of, accessibility for our patients, well, I think a lot of us who see this population kind of know, many of our patients might wake up before noon, and then by the time they, depending on how chaotic their lives are, they might make it somewhere in the afternoon or even, in the early part of the evening. So we just sort of try to get a sense of, okay, how accessible are our clinics based on hours? And so there is some good news. Just looking at these graphs, more than half of RAAM clinics, have at least about 5 full days a week of service, and about half of them have full coverage in the afternoons. But despite this, we still have about 11% of clinics that have no afternoon hours, and 11% of clinics that only have 1 to 2 half days per week. So there's still considerable room for improvement. Okay. And so there was right. Okay. And when we looked at weekend hours and evening hours, this was an area that definitely, there are some gaps. So 3 RAAM clinics listed in the Connects Ontario database offered any weekend hours, and there were only 36 RAAM clinics that offered any service after 5 p.m. And the definition of that was, having at least just 1 hour after 5 p.m. On any day of the week, from Monday to Friday. So, going over, things provincially, we can see, we all can see that, there's been a sizable increase in opioid morbidity and mortality in the province. And what I found interesting about this graph going back from 2003 till now is that despite the large increase in the number of ER visits and the considerable increase in mortality, the number of hospital admissions is still relatively the same. And so there's a definite mismatch here. Okay. And it speaks to sort of the barriers to care that are in the system from this graph that you can see. And the four main things identified, by patients on survey data has been, stigma, fragmentation of the system, access, and geography.
Additional barriers for Indigenous people. This here is a picture, a painting by Kent Monkman. Kent Monkman is a Swampy Cree from Manitoba, but resides here in Toronto today. The picture is very, very powerful and is almost tough to look at sometimes. When we talk about barriers, it's important to note that barriers are different from different populations. Indigenous people face specific challenges. Just by looking at this painting, we can see why so many other community members face many barriers on a day-to-day basis. This painting by Kent shows what happened to our children. Our community members have issues going to school, maintaining jobs, self-esteem, issues with alcohol and drugs, all stem from historic events. What has happened in the past holds to our future, and we need to make changes so that we can change our future and continue our healing. Culturally relevant care, we are going to focus on four main barriers. There's been a lot of interest lately in land-based healing. We've been doing this for many years at AHT. Prior to this, our community members had to travel to the far north for ceremonies, sweat lodges. They didn't really exist in the city, and some of our people didn't believe they belonged in the city. But I know they were needed here because members couldn't get out of the city, couldn't afford to leave the city. So we had to build our own land-based healing here. This is for helping communities find their culture has been a huge difference in our lives and will impact the lives of future generations. Like the sweat lodge, which we usually have in the back of our building. It's really a significant ceremony on, it's about purification. It's about a new beginning. When you go in there and when you come out, it's like you can start over again. And, this has been a very important part of our healing. And with the pandemic, it's really made a large impact on the lack of ceremonies today. Also, the banning of ceremonies still exists today, even within our own communities. And that's due to lack of knowledge from generations of oppression. In the North communities, there are language barriers, cultural barriers, limited access to traditional medicine. And these are often worsened when our community members have to travel to urban areas for care. Systemic racism, I think many people will know these names from recent events. And 3 years ago, when the story of Brian Sinclair was, he was left in a hospital room or a emergency department, and he died in there after 2 days of just being ignored, basically. And Joyce Eshkawan 2 years ago had the similar problem, but she reported her abuse. She recorded the nurses and other people with hospital staff abusing her, neglecting her, and she eventually died as well. And after that neglect happened, only 2 staff members were fired, one being a nurse. Would the outcomes have been different if they were non-Aboriginal, if they were white people? I think it would be quite a difference. And additional barriers for Indigenous people. The next thing, the next major barrier our community faces are long-standing mistrust with all current government system, which includes the healthcare system. As recent as last year, our community members had a hard time believing in government health policies and recommendations due to reoccurring events like what happened at Saugeen First Nations, where they received expired vaccine doses over a period of weeks. This is history of harm, and the harm is still ongoing, and this has to change. Intergenerational trauma. The last residential school closed in 1996. Prime Minister Harper issued an apology, but this did little to build the trust of our community. What does intergenerational trauma mean? Our culture was eradicated. The entire population suffered, losing their children and identity. This trauma is carried forward by the next generation to come, and each generation adds on their generational trauma as well. So to sum it up, it's not what happened to our elders at a static event, it's what happened to many of our ancestors is happening to me, and what will carry forward to our children.
Okay. I just want to go over a couple of other interesting reports that we sort of came across as we were preparing for this presentation. And this one I found quite interesting. So the National Report on the First Nations Regional Health Survey, which was done in 2018, was a cross-sectional survey of First Nations people of all ages, and it was quite a large sample size of nearly 23,000, just shy of 24,000 people in over 250 communities with a very high response rate. So to put this in perspective, many surveys have a response rate of 10 to 20%. This was nearly 80%, so it's quite high. And there were two things that were striking. So one, the barriers to accessing traditional medicine. 23% of people lacked knowledge or were unsure where to access traditional medicine, and 12% identified the lack of access in healthcare settings or costs as a barrier. This data speaks to the disconnect that people have from their culture. At AHD, we've been focused on providing traditional medicine services, harvest and trade to promote the healing within the community here in Toronto and to improve access to traditional medicine. Now this was another interesting result from the survey. So, I mean, this graph really shows the limited access to health and mental health services. So about 73% of respondents had access to a nurse or physician within the last year. And this is really surprising given the high burden of chronic disease that we know is in the First Nations population. And when we looked at mental health services across the country, this result's even more alarming. So about 70, just over 70% of people who wanted access had no access to a mental health service. These disparities are quite alarming. Okay, and then the third piece of information that we found in terms of self-reported challenges within communities. So alcohol and drug use was identified as one of the common challenges by 80% of First Nations youth and adults, well ahead of other priorities such as employment, funding for services, violence, etc. So this is to sort of sum up, a lot of the things that, come out of the results. We picked one of our patients, who we'll name Tina, and her story kind of encapsulates a lot of, I think, what is in the early part of this presentation. So I'll just quickly read off this story. So Tina's a 32-year-old woman with substance use disorder for 15 years who resides in West Hill, Scarborough, with two other individuals. All through her 20s, she struggled with alcohol use disorder while working in the restaurant industry. Her recreational then use developed into substance use disorder as she was unable to keep steady employment. Her drug use included cocaine, heroin, and in the last 3 years, fentanyl. She participated in Anishnawbe Health's AMHA, that's Addictions and Mental Health Day program, and attended the drop-in service 5 days per week for 20 weeks. When the pandemic occurred, AHT was not able to offer in-person day programs when they were to a virtual service. Tina did not have the tools, phone, computer, or internet, to participate. Being isolated from services contributed to Tina's relapse as she started to consume fentanyl again. She lost all her ideas and was not able to apply for OW or ODSP. Most days, she would spend her time at home trying to manage her withdrawal symptoms on her own with the street supply. She tried to access addictions treatment for 2 years prior to learning about AHT's RAAM. Tina last saw a medical provider in her early 20s and reported that she is not comfortable going to hospital or accessing healthcare services due to her self-inflicted stigma. So with the support of one of our RAAM case managers, Tina made it to her phone appointments with us. She was started on opioid therapy and connected to OW services right away. 1 year later, she's stable on her OAT and has resumed going back to work full time. She also attends the AMHA program, which is now offered in a hybrid model, both virtual and in person. And she identified the following barriers she faces daily. One was the lack of evening services to pharmacies in the GTA and to many clinics that would dispense methadone or Arcadia. The lack of primary care services for Indigenous people in Scarborough, where she resides, and the long commute to Anishnawbe Health in downtown Toronto for in-person day programs, which includes access to traditional medicines.
So thanks, Chetan, for Tina's story. So like Tina, many of our clients here were really struggling, and as many individuals across our country and the world, were really struggling with accessing healthcare services. Now, particularly for our RAAM, we were seeing our clients walk in, and then all of a sudden, when they were getting kind of displaced in the city due to many reasons. It could be housing related, or either they tested positive for COVID and they could no longer stay in the shelters here, but they were kind of displaced either to Mississauga or to Scarborough. We found that they were just really having difficulty accessing a provider. Now, our folks in the West End, in some of those isolation hotels and shelters, the city had some good supports in those hotels with nurse practitioners and nursing staff to continue prescribing of oat. But we found that there was a disparity in Scarborough with a lot of the shelter hotels there. A lot of our clients couldn't even access the pharmacy or didn't know where to access the pharmacy that would dispense methadone, or they were really traveling a long distance to come downtown to access our services here. So it made us look at Scarborough in a little bit more detail. And we thought, okay, if our clients can't get to us, let's try to get to them. So we thought, okay, how can we develop a program? And so we looking at a good framework for planning. We started off with our environmental scans. So we looked at Scarborough. Now, where in Scarborough in particular are our clients residing, and where are there some major gaps in providing addictions medicine service? And we found many of our clients were living in the Kingston, Galloway, Orton Park area and West Hill. And we also have some existing partner relationships with some of the agencies there, like Native Child and Family Services, Gabriel Dumont, other housing programs and shelters. And we also found that a few of our clients who were residing in encampment sites in the downtown core were kind of going towards more isolated sites in West Hill. So we had this idea that, you know, there probably is a large portion of Indigenous people residing in that area. And then so we looked at, okay, well, what does the census data say? So 2.2% of West Hill residents identify as Aboriginal, compared to 2.8% all over the province. Now, we know that those who identify as Indigenous, that number is an underrepresentation of the actual numbers. And we tried to look at, okay, what else is happening in this area? So we know that, you know, there is higher rates of poverty there. The unemployment rate is higher. And when we compared it to the city of Toronto, we found, you know, there is a densely populated number of our folks who do live in that area compared to the rest of the city. So 2.2% compared to 0.9%. So we really wanted to have a closer look. This next slide is actually from the local maps, and I highly encourage everyone to look at this interactive tool. So we wanted to see, you know, the earlier maps that we showed in the presentation highlighted some healthcare deserts. We also wanted to look at, you know, what other, and we know addictions was a challenge for many of our clients who reside there, but what other challenges is the community experiencing? So we found that, you know, there is a higher prevalence of diabetes in that neighborhood as well. And we know from our community members and our clients here that diabetes is also another major challenge. Again, we wanted to really look at what services are there. So this next map just shows access to primary care. So this is in particular to family health teams. There really are no family health teams and no primary care services there. So again, it really correlated. Some of the earlier maps we looked at were 2016 data, and this is 2019 data. So there hasn't been much of a change. So what our clients were telling us when they say they can't access a physician, they can't access a doctor, they can barely access pharmacies that dispense all their medications, you know, it really correlated with the data that we were seeing. Our next focus was to look at, well, how bad is the opioid epidemic there? So we decided to look at some EMS data. So EMS data here, this is from July 1st of 2021 to June 30th. And you can see that West Hill area there, you know, it is there is a significant amount of opioid overdose calls by EMS that gets received. So they're in the top 15 of the number of calls. But again, I guess what the difference is from the other areas that are darker on the map is that there are, you know, limited services or almost no accessible services for addictions medicine in that area. And when we called all the pharmacies in West Hill, there was only 2 pharmacies that dispensed methadone. So that was pretty eye-opening for us. So we decided to, you know, look at what do we want to achieve in the next couple of years. And again, we started this process about 2 years ago. So we wanted to increase access for medication for our clients. And we also wanted to kind of bridge some gaps between Western and traditional services for our community members. We were hoping to also decrease morbidity and mortality rates. And again, you know, as Harvey had mentioned earlier, AHT has a history of going mobile and providing services to everyone all over the city. So we really would like one day to expand those services all across the GTA and really look at those other healthcare deserts in the city as well. We knew, just like all other agencies across the health sector, that we are going to have Some challenges, so some internal challenges would be staffing and funding, because we're not getting any more money to provide these services, and we wouldn't be able to expand our staff. So we really had to look at, how can we build capacity. And some external challenges that we're facing are, having pharmacies dispense opioid agonistic treatment, including methadone, KDN, and Sublocade. In the West Hill area, we couldn't find one pharmacy that was currently had Sublocade in stock. And the other major challenge that we were having was really engaging with our clients to seek services outside of AHT to kind of help them along their journey of healing. So we decided, let's come up with a few solutions, and then we can kind of focus in on one. So we thought, maybe we can partner with existing healthcare services near the West Hill area. There is one pharmacy there that was already quite engaged with a virtual service to provide addictions medicine, but we knew from our clients' feedback that they really didn't want to speak to a doctor over a screen. They really wanted to have the one-on-one engagement. We maybe even considered at one point, should we put another satellite location in West Hill? So we have 3 satellite locations in the downtown core. We're walking distance to each other. Or should we go mobile, like we've gone mobile with our COVID vaccine and testing and our primary care services. And then again, another option was, should we, try to partner with one of the pharmacies and do a virtual care service only? And we decided we were going to go mobile. And this is really based on the success of our mobile services, historically and also currently, as we provide daily COVID-19 vaccine and testing. And we're all over the GTA. So we knew that mobile was, part of our culture, and we could do this. Also, going mobile is really embedded with AHT's strategic priorities as well. So we decided we were going to bring, provide the following services. We would have a physician on the vehicle. We would have a case manager to provide short-term case management. We would also have an outreach worker for engagement of our community members. And then that service would bridge the gap, hopefully, to providing additional services at AHT, which includes traditional services, primary care services, our Aboriginal Mental Health and Addictions Day program, our housing support services, the full works. We would partner with a local pharmacy, and we would be as low barrier as we possibly could be. So no ID required, no appointments required, and we would try to be as discreet. So this is actually a photo of our current vehicle that goes out on Wednesdays. So it doesn't say addictions medicine, it just says Anishnawbe Health. So just to be, as discreet. And this next photo is the pharmacy that we have partnered with. They were one of the 2 that was dispensing methadone. And they were really interested in working with us because they've also seen the need in that community as well. The pharmacy actually approached us and said, can you also provide hepatitis C screening and HIV screening as well? Because they've noticed that there's also a need for that service there as well. So we actually went off the ground earlier last week. We will be there every Wednesdays from 12 to 6. We hope one day that we can do this every single day of the week. So the current services that we're offering on the vehicle is anyone who registers for the mobile RAAM will have full access to all of AHT programs and services. We do provide transportation like tokens, and we will provide through case management and support virtual access to our other programs here at AHT. So this includes counseling, traditional medicine, primary care, the full works. Again, we don't need appointments, it's only walk-ins, no ID required. Our case manager will support our clients in any housing related concerns or income support, or or even getting ID if the clients are interested. A year from now, we'd like to, see if our program has made any impact. So, we will, like we evaluate all of our other programs here, we're going to get some feedback from our clients, through surveys and interviews and having town halls in that area and see, how can we make the service better. We're going to look at some indicators as well. How many ED visits are there for our clients? Many of our clients here, when we see them here, we notice that they've had a revolving door type of experience through the EDs, and then they come and they see us. And once they have, a number of visits here, we do see ED visits go down. Are we going to see the same impact out in West Hill? How many EMS calls that are related to overdoses will there be in a year? And how many overdose-related deaths? For the eviction notices, we've actually heard from our community partner agencies there that recently there's been a higher number of eviction notices that have been handed out, and they suspect that a lot of it is related to drug use. So we're hoping if we can provide those services there, are we going to see these eviction notices also go down in those partner agencies, in those community housing agencies? So what's our hope for the future? The photo here is actually where it's a picture of what our new building is going to look like. So we're actually going to be moving to a new site near the distillery area. So we hope that, a year from now or 2 years from now, that we can also partner with other First Nations agencies in the GTA, because we know we won't be able to, do this alone if we want to go to all those other healthcare deserts in the city. And like our pharmacies that we're partnering with has mentioned that they've seen a need for Hep C and HIV screening. We're hoping that this could be something that we can measure and also provide as part of our RAAM service on the mobile unit. And of course, our main goal is to stabilize our folks who are struggling with substance use disorder, so we can help them facilitate long-term cultural healing and bridge some of those gaps for traditional medicine. So that brings us to the end of our presentation. So we really just want to thank everyone for joining us today. And as we say thank you, miigwech, to all of you for joining us, and we'll take some questions.
Thank you guys so much for that presentation. From start to finish, with giving us, some of the backgrounds and barriers, highlighting those. And I really appreciated and liked the highlight of the lack of services that are available. I think we all see them in our practices on a daily basis, and it was even more shocking to see it quantified on the slides that you shared with us, and then to show the ways that you tried to address those gaps. So you have a couple comments and some questions. I think they're more comments that people are hoping you might be able to give your insight and feedback on. So I'll read those out now. Going from the end to the start, I guess. So one person says, I would like to extend primary care, which addresses addictions and substance use disorders, to First Nations communities in Northern Ontario. Some are 1 to 5 hours of driving apart. They'd be happy to receive any recommendations, ideas, or support. So I guess it kind of plays into what you had highlighted as that desert area, that gap that you'd identified in the GTA, and how you address that with the mobile service. But I know you had spoken about there were different options that you were considering to address that. I don't know if you have any ideas for how Northern Ontario might go about something similar.
I think Northern Ontario, they are also starting their own mobile service. And I think it's a really great example for how it would work out there, because many of the reserves are 1, 2, or even 3 hours apart. But you could extend that primary health care right across the northern shore there and get doctors to 2 different reserves in one day. So I think that's a really great example is the mobile. Kind of like here in Toronto, like we have really no services in many parts of the city that Aboriginal people actually trust. So, having a mobile that goes to Scarborough or goes to North York, it really totally makes sense to me. And if we can fly a judge into different reserves and penalize, people for alcohol or drug addictions, we could surely get some kind of other kind of help so that doesn't happen.
It just makes sense when you say it that way, for sure. To follow up on what that person had kind of posed, and something that I think you'd mentioned earlier in your presentation when you were deciding how you wanted to go about supporting this desert region, what would your thoughts be just from the clients that you see and the way that they say they do or don't like the services that are available for those regions? Is it better to do the mobile services or to have these virtual and digital services that are popping up now because of COVID? We know that they're expanding, or a combination of them that's accessible. What are your thoughts?
Well, I mean, I think most of our patients prefer seeing somebody in person, and having telemedicine is great because at least it's providing service in many areas where there might be little to no service. But I think most patients prefer actually seeing somebody physically in person. And also, there's certain things that can be facilitated, more easily. Simple examples, actually doing SUBLOCADE injection. So, one of the comments we've heard from patients who've been accessing virtual services is, hey, this is nice. I can actually have an injection. So, that's a simple example. But, I think we all just generally like to see somebody in person as much as we can, especially after the experience of the pandemic.
Yeah, absolutely. You have a couple more questions coming in, so hopefully we can get to all of them. The first is, I may have missed this, but does your mobile RAAM clinic run at the same time as the classic RAAM? Can you again discuss how staffing works for your mobile RAAM? If you could just run over that again.
Yeah, so right now we only have Dr. Mehta as a prescriber in our RAAM services. So for that for that Wednesday afternoon, there won't be a physician on site here. But we do have a coordinator here on site with also another outreach worker. So we communicate by phone. The whole team actually communicates by phone. I think I saw a question that came up about how are we, using digital tools. So we, on the RAAM mobile, we're completely paperless. So it's all communicating through our EMR. And so, once we get busier, we'll have to talk about staffing again. But right now, our coordinator will be kind of messaging us back and forth about what the needs are here. If a client showed up here, can we get them on the phone? Can we see if they can talk to Dr. Mehta, even if he's out in Scarborough? So we really are low barrier, and we really are opportunistic with every client that walks in. We really try to have someone provide a service, whether it's a case manager, an outreach worker, Dr. Mehta, myself, any of our team members, really.
Yeah, perfect. And obviously in need of more funding to expand, because it sounds like there's such a great need. So I'm glad that you're here speaking to it. More questions that are coming up. I don't know if you'll be able to answer this one because it sounds like you're still in the process of gathering data, but can you comment on the breakdown by age? Are older adults among those you provide outreach to, and what proportion are older? And I'll add to that one, older and younger, just out of curiosity.
So, the short answer is it is very early. We had our first inaugural shift last week. So a lot of what's happening at the moment is relationship building between some of the other agencies, Indigenous or agencies like Native Child and Family or Gabriel Dumont, to, you know, let them know we're there. And then slowly, hopefully, we'll start to see a trickle coming in, and then we'll sort of see what walks through the door.
And just to add to that, our vehicle is, there's two like exam spaces in there. So one for case management, one for the provider or prescriber. And it's more of like you know, we brought the typical exam space, clinic space into the mobile. So we can try to see two individuals on the vehicle. Yeah. Now, in our partnership with the pharmacy there, they actually also have exam space that we can use as well if needed. So it gives us a little bit of flexibility.
That's nice. Amazing. Someone asks, and maybe you just address that one, but just to ask it outright, how about group visits, which seem like they might be something that's important or asked for by community members? For the mobile van specifically, are group visits or even just having family or friends present for visits, is that a possibility or not so much?
I mean, the short answer is we're going to play this by ear.
Okay.
You know, it really is going to be patient driven as to how they want their encounters to look. You know, space is going to be a little bit of a challenge on the mobile, but you know, we're going to try and work around that. Also, you know, the pharmacy that we've at least partnered with close by, they also have some space. So, you know, it's going to be a little ad hoc in the beginning. I would like to say, you know, one of the other things that sort of has really inspired, you know, or helped to inform, you know, our vision of the mobile services was, you know, looking at the Portugal model. And what's very interesting is that, you know, Lisbon has had a mobile service for well over a decade now. And about a third of the patients in the city of Lisbon access their methadone through their mobile service, which runs 365 days a year, rain or shine, is fully staffed, and very low barrier. Now, will we necessarily get there? Maybe, I don't know. We're going to sort of course, play this by ear, and there's going to be an evolution over time, and but really it's to, you know, really expand the accessibility of these services in healthcare deserts.
I'm so glad you said that, actually, because that's where my brain went when Harvey, when you were speaking, and I don't know if that's where the other participants' minds went as well when you were saying, you know, why criminalize when we can spend our resources instead on preventing even getting to that stage and jump in before there. So I'm glad that you made the comparison, because I definitely felt it myself. You have a couple other maybe bigger questions, so I'll bring those up. Are you able to share what the process was like with getting senior leadership on board to diverting resources to this project, and especially rostering a whole bunch of new primary care patients? Who wants to tackle that one?
Yeah, that is a big question. It was a challenge for sure, especially when you're within an Indigenous agency, and there's so many challenges regarding drugs and alcohol. And, you know, we had to, I think once we did get senior people involved and understanding what we're trying to do, I think it went actually quite easily. And they were quite helpful in preparing and getting the whole proposal together. I actually think we couldn't have done it without, obviously we couldn't have done it without the senior management vision.
Yeah, fantastic. Another I think a bigger question, that's great. You're getting lots of excellence in those kind of comments as well, just in case you can't see them. A question that is important for me as well, I feel this one. They say our RAM in Toronto receives a large number of clients from the affiliated WMS, or withdrawal management service. Do you have any suggestions for making the WMS and RAM clinic more accessible and welcoming for Indigenous to clients? And to add to that, I know the withdrawal management that I've worked at previously sees minimal to no Indigenous clients, and it is not because there's not a need. So I'd love to hear your thoughts on why that is and how we can improve it.
I'll just quickly start. When we first started the RAAM here, we didn't know what to expect, and from that day until now, we are saturated with people that we just can't see them all. We need more staff we need more Chetans and Subos, because it's just so many clients. And I kind of feel that's maybe the direction that may happen in Scarborough as well. But you go ahead.
Yeah, I think one of the challenges is, like we said, specifically for our Indigenous clients, is they really want to be able to access multiple services. And I think that's what makes AHT a bit more suitable, is that they can come in, for RAM, they get that case management, they get that traditional aspect. And I think, you really have to have a holistic approach. And again, like, it's more like through word of mouth in our community members as well. It's, we have a lot of people who come in here and then they bring their friends, they bring their family members, and we're well above our capacity. So looking at what other RAM services can do to kind of cater to our clients would probably be a bit more of a holistic approach. Yeah.
The other thing I would add, I would say the hours of the RAM, I think, are important. And for us, we start to see a real pickup in the afternoon hours for our patients. I think we know from sort of Toronto, City of Toronto data, that about, I think it was the 2021 data, 23% of people who are sleeping outside identify as Indigenous. And so if you're working with a homeless population, we know that people who are sleeping outside, things are very chaotic for them. They're sometimes get little to no sleep at night. They're constantly facing the threat of being evicted by the city. So they just don't make it into clinic, until the afternoon hours. So,
yeah. We're at, I'm so sorry, we're at 12 o'clock. So that was fantastic, but there's a lot of questions and comments that we didn't get to. So if there's a way that we can share your information, or if you don't mind people reaching out to you on the platform, I'll remind everyone that you can connect with people in open chats and meetings with them privately if you want to follow up with any of the presenters. You got a lot of thanks and thank you along the way. For everyone that's on the line, it is your lunch break from 12 to 1. There is yoga that's happening at 12:10. I believe that starts with Nancy Silverman if you want to join in. And the afternoon sessions start at 1 o'clock. Thank you guys so much. I'm sorry to have to cut you off because there's so much that we still didn't address and people are really interested to connect with you. So thank you for being here today.